Okay, so let's start.
Okay.
Can you hear me, everyone?
Yeah, we can hear you, Pradeep. Yeah.
Thank you so much. Okay, good evening, good afternoon, and good morning, right across the globe. We have a very eminent faculties from all over the world. We will be talking on tendinopathies here from the masters, and we have Professor Nicola Maffuli, who is a professor of trauma and orthopedic surgery and a consultant from Queen's Mary, London, and has published close to 1200 peer review articles. And I don't think so anybody needs to know that he's the master if as long as it comes to tendinopathies. So we really have a great person here who will be talking on Achilles tendinopathy, 10 things to know. Then we have Dr. Anish Kadakia, who is an associate professor and a very close friend of mine. He's a program director of foot and ankle surgery at Northwestern in Chicago. Hi, Anish. And next we have Dr. Balwinder Rana, who's from Delhi, who's who's an associate director and in charge of foot and ankle unit from New Delhi, from Max Hospitals, and he's been a past president of the Indian Foot and Ankle Society and a very close and dear friend as well. Thank you very much for sharing your time and spending your valuable weekend for this symposium and webinar. So we'll be talking on tendinopathies, mainly around the foot and ankle. So without wasting any more time, hand over the screen to Dr. Nicola Maffuli. Please, sir.
Oh, hi. Thank you very much for inviting me here. It's a great pleasure to be here. Now, let's see if I can start sharing my screen. What can I? So I don't know what you've done, but my sharing bit is gone. Let's see. Can you see?
At the bottom, Nicole?
Yes.
There it is, brother.
We can see you.
We got you, man.
Yeah, we can see your screen, sir.
Hey, I will say it's a great pleasure to be with you, at least in the ether. I love coming to India. I've been over with you many times, and I've got plenty of friends in India. I do have some conflict of interest in that I'm a very good friend of Dr. Kadakia, and we share the same barber, as you can see. I go back and forth all the time between Italy, my home country, and the UK. I'm still a professor in the UK at Queen Mary University of London and Keele University School of Medicine in Stoke-on-Trent in Midlands. But now my substantive appointment is in the oldest medical school in the world. If Bologna tells you that they are the longest standing medical school, or Padua comes up with this kind of statement, don't believe them, because history is different. And medical schools, as we know them now, started in Salerno, to the south of Naples. I'm sure you will have heard about the Amalfi Coast, and Salerno is at the south end of the Amalfi Coast. And the medical school there dates back to the 9th century. After four guys, a Greek, a Latin, was a Christian, a Jew and a Muslim got together and started the very first intercultural medical school in the world. The medical school was closed when southern Italy was conquered by Napoleon at the beginning of the 19th century, and then it was started again about 12 years ago, and I've been there since 1213, going, as I was telling you, back and forth from London. We do have, I'm the head of the research program and the head of the residency program, and we have a simple motto: we never finish, we only stop for a while. Some of you beforehand asked me why I was so interested in soft tissues. In 1987, I was appointed a lecturer in orthopedic sports medicine at the University of London. My boss at the time was the now defunct, unfortunately, John King. And over the first 2 weeks of my job, John told me, Nick, bone always heals, cartilage never heals, tendon, muscles, and ligaments is where we can make a difference. And therefore, since then, my aim has really been to try and make a difference. I've concentrated mainly on tendon, muscle, and ligaments, and therefore, to some extent, in sports, I've concentrated my working life in sports medicine. But being a classically trained orthopedic trainee in the UK, I had to deal with a lot of fracture surgery. And as of late, because it's challenging, because cartilage never heals, we started to work more and more on cartilage, even though I cannot claim to be an expert in any of these things. Tendons do passionate me because when I was a young man, I used to run a bit, and I ended up having an Achilles tendinopathy. And I discovered at the time that there was not much evidence in that respect. And so with John, we started to focus on tendon problems. We're going to talk today about Achilles tendinopathy. And the first single most important message that I should put forward is that even though Achilles tendinopathy is Achilles tendinopathy, and occurs at the artery around the Achilles tendon, please remember that it is not always an overuse injury. And that's probably the single most important message. These are all things that can be diagnosed in patients who have pain at and around the Achilles tendon. As of late, we have London has been an epicenter of HIV infection, and together with some of my infectious disease specialist colleagues, we have put forward the idea that the Achilles tendon, the surrounding tissues, could be the first manifestation of HIV infection. So consider this as well in your differential diagnosis. Today, I'm going to spend the next 15 minutes or so talking about these 10 things that we should know about Achilles tendinopathy. As I said, avoid stereotyping. Achilles tendon problems not always arise from overuse. Indeed, it has been at least 1 decade that we started studying the influence that hormonal disbalances and dysfunction may cause on tendons, but especially the Achilles tendon. It may well be that the missing link in all this is metabolic diseases. We have looked at several hormones, and we now know that, for example, problems with your thyroid may induce an Achilles tendinopathy. We all know that diabetes, for example, does exert a negative influence on tendons, and that obesity and metabolic syndrome cause a status of, it's called metaflammation, a background of low-grade inflammation which can negatively affect the tendons. Also, it may be that some of us are just predisposed to developing tendon problems. This is a study which we conducted with Football Club Barcelona. Several of those doctors have been my fellows along the years. And we studied the genetic makeup of essentially the best footballers in the world. And we saw that some of them have inherited from their parents the propensity to jump higher, to jump longer, to run faster, to run for longer, and so on. But some of them have also inherited part of the genetic makeup which makes them more prone to developing soft tissue injuries and tendinopathy. We extended those studies, and now we know, after having studied some other polymorphins, that some of them have inherited the right genes to be a better athlete, the right genes, unfortunately, to be injured in terms of soft tissue injuries, but also some of them have the right genes that allow them to recover faster. So it may well be that the perfect athlete, the athlete who will be successful, is the one that, yes, may get injured, but may be able to bounce faster from that injury. There are many myths in this field. Please do not perpetuate them. Tendinopathy is not self-limiting. It is not true that conservative management is not useful, and it is not true that rest is not necessary. On top of all this, please remember to interact very closely with your rehabilitation specialist. I am lucky in that I've always worked in teaching hospitals, and so I've always had a good team of people around me. I've been lucky because I've always had the help of rehabilitation specialists. And this is important because it doesn't matter how good an orthopedic surgeon we are, because a rehabilitation specialist will know more about rehabilitation than we'll ever do. If this is not the case, if you found out that your rehabilitation specialist doesn't know more than you do about rehabilitation, then change rehabilitation specialists because they will not be helpful. Unfortunately, if you interact with these guys, and I hope you do, then you'll have to be able to talk their language. And therefore, you need to learn about modalities of contraction, such as eccentric, concentric, and concentric exercises, plyometrics. You have to know about Tabata training, occlusion training, and so on. You have to make friends with them. And the other kind of friend that I would prompt very much you to have is a rheumatologist, because there is now emerging evidence that inflammation is playing a role in tendinopathy, and they will know more about inflammation that we as orthopedic surgeons will never do. Another myth is that you need to have a good team about you, because success after well-performed non-operative treatment is only 65% in terms of less pain. But only less than 45% of patients are able to return to pre-injury level if they suffered an Achilles tendinopathy. And by return to pre-injury level, we mean at the same level in the premiership, for example, in football, at the same level of playing the same number of games all through the years. And therefore, if this is true, it is best to avoid prolonged conservative management. There is probably a watershed at 18 months from the onset of symptoms. Already in the 90s, we showed, together with the work that we performed with Peter Binfeld and David Moore, and obviously John King was our leader at the time, that after 18 months of conservative management, it doesn't matter what you do, whether you continue conservative management or even if you implement surgical management, there's a drop in success rate after that time. It may well be that the biological potential of the tendon is being exhausted after that time. If this is the case, then it doesn't matter the kind of stimulus we give them, either non-operative or surgical, the success is not going to be that great. I interact very closely as well with imaging specialists, with radiologist colleagues. And what we have found is that, yes, there are many modalities that can help. Pain radiography is one of the things that can be helpful in order to see whether there are associated bony abnormalities. Ultrasonography is very, very heavily used in our setting, simply because I have excellent ultrasonographers, and my radiologist is a great interventional ultrasonographer. We believe that MRI is probably grossly overused, and indeed the present evidence shows very clearly that a good ultrasonographer is worth their weight in gold. In general, however, once the diagnosis is made, repeated imaging does not benefit the patient or you as a surgeon, it only benefits imaging specialists. And please remember that there is no relationship between the presence of neovascularity in tendon and symptoms. A tendon may be grossly neovascularized, but not be terribly symptomatic. We love injecting, don't we? And we've injected just about anything around the tendons. But please consider carefully the role of injections. Corticosteroids are grossly overused, but please beware of rheumatological conditions. Since 2001, we have used high-volume image-guided injections targeting the neurovascularity and the neovasculature in these tendons. Somebody inevitably will ask me, what do we inject when we inject high volumes? And the answer is very simple. High volume of saline is what will do the trick. PRP is very fashionable and probably is overused because essentially all the randomized controlled trials performed by independent centers have shown that it is not better than homocysteine. Sclerosing therapy with hyperosmolar glucose or sodium morphate seems to have some role in some specific pathologies, and therefore prolotherapy is any evidence. Biologicals, including PRP and including MSCs, mesenchymal stem cells, are fashionable, but they are probably overused. These are a few papers that you may want to consult regarding high-volume injection, high-volume image-guided injections. And it is of note, interesting of note, that high-volume injections have been independently tested by a group which doesn't have any ties with us versus PRP, a group from Copenhagen. They've shown that at 6 months, high-volume injections are more successful in the management of Achilles tendinopathy compared to PRP. We are surgeons, but please do not list everybody for the same operation. Indeed, in this field, we have several options. The gold standard is probably open surgery. We have described percutaneous longitudinal tenotomies and other minimally invasive stripping techniques in order to tackle the issue of Achilles tendinopathy. And I personally have a very high threshold for tendon transfer for tendinopathy itself. I spoke about minimally invasive procedure, and we have described percutaneous longitudinal tenotomies, minimally invasive stripping, and endoscopic assisted procedures. Any of these can be performed, but please remember that it is a question of horses for courses. Not everybody should be listed for the same operation. Also, please remember that the fact that it can be done minimally invasively does not mean that it should be done. And although we may believe that we are better than the surgeon next door, because we all, as surgeons, we all believe that we are above average, please remember that a well-performed open procedure is better than a half-baked minimally invasive procedure. The reality is that when systematic reviews are performed, successful results are not as common and we're not quite as successful as we like to believe. And that success only occurs probably in about 70% of patients. And excellent results are not always observed in real clinical practice. And all in all, as we were discussing with Dr. Kadaki only a second ago, patients should be informed that there are complications, and the complications do occur and they can occur. In this field, infections, lung nerve problems, ruptures, and DVT, and even pulmonary embolism are a reality. Do not promise what we cannot achieve. Even minimally invasive surgery does not reliably return Achilles to sport in 3 months. And one of the things that I find it very difficult to explain to patients is that it takes a long while for a tendon which has been painful for a long time to return to normality, or at least to return to relative normality. And even if you are in teaching hospital, you need to be having high-volume surgeon with a specialist practice to achieve good result. And the single most common cause of failure of technically well-performed surgery is attempts at early return to sport. It doesn't take 6 weeks to return to sport. It takes probably 6 months. Finally, please remember, ask for help. A specialist is somebody who knows when to call a specialist. And if you're working in an interdisciplinary team, then you will have your pal next door to whom you may call for help when it's needed. You know, every so often we do need a good shoulder to cry on, and 4 eyes are better than 2. Thank you.
Excellent. Thank you very much. Excellent talk. Can I start with some questions, Nicola?
Yes, sure. Should I stop sharing?
No, just keep it there. That's fine. Okay. I think so. Can I call you Nicola, or shall I call you Professor?
Nick.
Nick. Excellent. I think for a lot of people, people would want to know, what do you mean by Tabata training? You said Tabata training and occlusion training.
Tabata training, now both Tabata training and occlusion training have been starting in Japan. And Tabata training is a method, is a very high intensity interval training. Is 20 seconds on, 10 seconds off for 4 minutes only. It's very fashionable now in high-level athletes, and it is something that you need to know about because your patients may want to know whether it's effective or not in the rehabilitation process. Occlusion training is another type of training whereby essentially you put a tourniquet at the root of the limb and you ask the patients to continue to perform exercises until they cannot any longer, and then you keep the occlusion on for a few minutes. And this is said to speed up the process of hypertrophy and rehabilitation of muscles that have been exercised undergo.
Okay. One more question I wanted to ask was, say if a routine normal patient, middle-aged patient coming to your clinic who is a non-player, how long would you
Sorry,
wait?
say again. A normal patient who comes to the clinic.
Normal middle-aged patients come to the clinic who is a non-athlete with a
himself walks into your clinic.
Sorry?
Somebody like you who doesn't know what athletics is walks into the
Yeah, and has an tendinopathy. How long would you wait for conservative treatment before you offer them surgery?
But the issue is not conservative treatment. It's appropriate, well performed, well executed, and well adhered to conservative management.
Okay.
What we normally suggest is 3 to 6 months of this regime. But this regime will have to involve an assessment of the whole patient. So, for example, in middle-aged patients, we do assess their metabolic outlook. And if they are obese, we try and normalize their weight. If they are diabetic, we try and normalize their diabetes and so on. Unfortunately, patients want a solution tomorrow. And it doesn't happen. You cannot have things happening tomorrow. If they've had pain for a long while and say they are smokers, they are overweight, they don't want to do the exercise and so on, I think that offering them surgery would be a recipe for disaster.
Okay. Anish or Balwinder, any question you have?
Nicola, for your massive defects, long time ago I learned from you to do an allograft. So somebody comes in with nasty tendinosis or failed surgery, prior mid-substance tendinosis, went terrible. What are you doing for them? Are you doing a graft? Are you doing a peroneus longus transfer? What are you doing for the person?
Now, unfortunately, in our hands, in my setting, the most common cause of failure of well-performed surgery is the fact that they came over to me. I told them that they would have taken 6 months to recover from the surgery. They've gone to the guy next door and they've been told that don't worry, 6 weeks and you'll be back. So they went over to be operated by this other guy, and then they come over to me with tragedies because it is no longer a sort of virgin territory. Okay?
Right.
And they've already failed one surgery. So if that happens, I re-explore them very carefully and I essentially do the operation. If I end up with a big defect, then I have to think about what to do. In general, I don't like using FHL in athletes simply because if they are, especially if they are, as I say, in football, be it American football or European football, soccer, if they lose their ability to grip the ground and push themselves forward because they lack FHL, is the difference between being elite and being a nobody, essentially. And so in these patients, I prefer, if I need to do a local tendon transfer, as you manage, I use peroneus brevis.
Why not the longest?
Peroneus brevis, I can use it through the same medial incision, as you know, I mean, we described the technique. It is untrue that I destabilize the ankle, and it is untrue that I limit the inversion strength of the ankle. These myths come from the fact that in 1988, when Jon Carlson wrote his thesis, his PhD thesis on ankle instability and use peroneus brevis, he showed that there was a statistically significant deficit using peroneus brevis. but this deficit was only 10%. So it is statistically significant, but probably clinically irrelevant. So if you then train your subjects to evert using peroneus longus, peroneus tertius, then this deficit doesn't come into play.
Why not?
I know that people like Liu Shong, for example, have started using FDL, so flexible digital longus. I don't have any direct experience in FDL, but maybe that Dr. Kanaki and maybe North America knows more about this than I do.
Anish, you wanted to say something?
Go ahead.
No, you wanted to say something.
Why don't you take the peroneus longus? I've never understood that. Why do you take the brevis, not the longus?
The function of the brevis can at least be partially supplemented by the longus. But the flexion of the first ray of the metatarsal is part and parcel of the function of the peroneus longus, cannot be supplemented otherwise.
Okay, because it's interesting. Because when we look at yeah, it does. When you look at peroneal tendon problems, which I'm going to talk about, most of our talk is to spare the brevis and the hell with the longus, because we take the longus all the time. So it's interesting, but in an athlete, that makes some sense. That maybe that first ray stability is compromised when you take the longus. That makes some sense. It does.
Sure. Balwinder, you had any question?
I can tell you another thing. Sorry, can we extend on this? We are talking now.
Yes,
okay?
yes, please.
Now, I'll tell you when I do knee surgery and foot and ankle surgery. Okay, so I do a lot of ACL reconstruction, and for redo ACL reconstruction, so when there is a failure of ACL reconstruction, one of the grafts that I harvest from the ankle is the posterior half of peroneus longus. Posterior half, okay? And I use the tendon stripper that I use for hamstrings, and I use the peroneal tendons just above the superior peroneal retinaculum, and then I isolate half of the peroneus brevis and I strip it off. And even in somebody as short as I am, I get about 24 centimeters of tendon, so it's okay.
So you take longus or brevis?
In this case, in this particular instance, I take a free peroneus longus graft.
Okay. Okay.
Okay. But it is for a special indication, which is failure of reconstruction of the ACL, when I want to use another soft tissue graft and I don't have any other grafts around there. So I mean, it happens in, I don't know, in 1 in 10 revision ACLs. So it's not very common.
Correct. Balwinder, any question?
Yeah, Dr. Nicola, in a non-athletic patient with Achilles tendinopathy, what would be your indication when you're operating the patient? What would be your indication to add some kind of a transfer, maybe an FHL? Would you never do it, or when would you?
Well, I try. Well, we have several other options than open surgery. Okay. And I've described, in the talk that I've given, I've told you about minimal invasive techniques. We can do ultrasound-guided, minimal invasive percutaneous tenotomies, whereby if this is the tendon, I can go in the area of tendinopathy, penetrate it, and then go up and down with my scalpel to a small incision in the skin, to a stab incision in the skin. The other option is stripping or minimal invasive stripping of the tendon from the Tagus fat. What we do in this case, we have 4 stab wounds, 2 proximally, 2 distally, 2 at the essential, the musculocutaneous junction, and 2 distally at the insertion of the Achilles tendon on the calcaneus. I then pass a suture thread at the interface between the Achilles tendon and the Tagus triangle, so it's anterior to the tendon itself. I retrieve this distally, and then I can strip it down. I can bring it down so as to free up the Achilles tendon from the cardiac fat. And then I can put a mosquito, for example, for one of the distal or proximal wounds and release the parathenium that way. And in this way, the advantage is that I've not touched the tendon as such. I've not operated on the tendon. I've operated around the tendon. If that happens, then the recovery is faster. The price to pay is that I get recovery to a decent level of activity in about only 2/3 of patients. But we have reported this, I think in 2018, in foot and ankle surgery, in about 40 patients. And if I talk to patients, there are two categories of patients who like this kind of procedure. One are sedentary patients in whom the risk of infection are high because essentially they may have metabolic syndrome and the like. The other ones are the footballers who are mid-seasons and they cannot lose the whole season to rehabilitate, and therefore they can have an operation, 6 weeks of recovery, and then they can start. And the other thing, obviously, is that if it doesn't work, we have not burnt any bridges.
Okay.
Have I answered your question?
Yeah, that means I would take that you would almost never do a tendon. Or even if
I have a very high threshold to do a tendon transfer.
That a large portion of the Achilles tendon is already degenerate. You would still not do a tendon transfer.
Well, remember that you need to take out more than 50% of the tendon for that tendon to be at risk of rupture or anything else happening. So we have a fairly high margin of safety in removing tendon.
Okay.
Okay. Two questions from online.
Yes.
One is from Dr. Siang. He wants to know is there any difference between Achilles tendinopathy and Achilles tendinosis?
I would remind Dr. Kian to read the paper that we wrote in 1998 where we were clarifying the nomenclature of these conditions. The term tendinosis was introduced in 1976 by Puddu and published in the American Journal of Sports Medicine. In 1998, together with Karim Khan and with Puddu, we introduced the term tendinopathy. Tendinosis is probably a misnomer, as well as tendinitis being a misnomer. And we propose that in the absence of histological evidence of tendinitis or tendinosis, this condition be called tendinopathy. As per usual, in the States, they are sort of, sorry Anish, they are about 20 years behind us in Europe, and only they start to talk about tendinosis when we already were not talking about tendinosis any longer. But the reality is that if you look at the internet and do a search, you will see that the term tendinopathy in PubMed is now being more used than the term tendinosis.
Sure. Okay. One more question. Are oral collagens effective in tendinopathy? I know a lot of pharmaceutical companies will come and this collagen, that collagen.
Yes.
Is there any effect?
The answer is that I don't know yet, but what I can tell you is that I'm involved in that kind of research as well, okay? And
Sure.
we're involved in developing nanotechnologies to deliver drugs in that area and using some more advanced things such as we worked on mesenchymal stem cell therapy, we worked on on nanotechnology to deliver drugs, but also microRNAs in that area. So maybe that in 5 years' time, by the time I'll be ready to retire, somebody will be able to fly the flag that way. Anish is a lot younger than I am, so maybe he will be able to pursue that kind of research for me.
I'm not that smart.
Sorry?
I'm not that smart. I'm a simple guy.
You're a lot younger and you're smart, don't worry.
Okay. One more question. I wanted to ask you. See, in India, so when I was in UK, what the percentage of insertional and non-insertional is what? 3:1?
Mm-hmm.
So we see in US and Europe more non-insertional than insertional, correct?
Probably so, yes.
Yes. In India, in my last 6 years of practice in India, I have seen 2 cases only of non-insertional.
Yeah.
and rest everything is insertional. And I see lots in a week as well.
Yeah.
Why do you think is the pathology like that?
Well, I have no idea, but what I can tell you is that in Italy as well, I see in proportion many more insertional tendinopathies than tendinopathies of the main body of the tendon. It may be that, again, being in tertiary referral practice, I see the troublesome patients, not the everyday patients. It is possible, and we just had a paper accepted by the Clinical Journal of Sport Medicine, that the patients who have insertional tendinopathy have a greater chance of having metabolic problems. And I would prompt that if you encounter these patients, you run a full metabolic screen in terms of diabetes, lipid metabolism, and so on. There is some anecdotal evidence that statins are associated with insertional tendinopathies. And unfortunately, statins are becoming more and more common in everyday life nowadays, both in Europe and in Asia, from what I know. And that is one of the issues. In the States, there is an epidemic, to my knowledge at least, there's an epidemic of insertions in their initial.
Yeah, there's a ton of it now. I would say in the last 10 years, I see more insertional, non-insertional. So like you, Pradeep, I don't know if that's, maybe because everybody's on a statin here too. It's very, very common.
Yeah, and I must confess now, the most troublesome patients I find are the insertion. These are the guys who are more disabled by the condition. These are the guys who will have in proportion more pain, and in whom everything you throw at them doesn't work, and therefore they end up with surgery.
Sure.
But I willingly did not talk about insertional tendinopathies, but we've had, I think in April, we had a paper published in the Orthopedic Journal of Sports Medicine. I don't know if you've seen it, Anish, the dorsally closing wedge osteotomy so essentially the Kelly osteotomy, which we modified because we also take a slice of the posterior corner. We also take out the posterior superior corner of the calcaneus. And now, in Europe, there are some guys who are doing all this minimally invasively with the burr.
Yeah, I've seen that.
It's impressive. I still do it with a small incision because it makes me feel better. But
so one more question. See, in insertional tendinopathies, when you operate and you have taken all the tendon off, you have taken the hagler.
Now I do a different operation. Okay. We describe exactly what you do. In the 90s, we described a very extensive operation, which was to expose the tendon, to take away, to detach the tendon from the insertion if need be, to hunt for the calcification inside the tendon, to remove the calcification, reattach the tendon with anchors, and possibly in those cases also do a graft, a tendon graft. We don't do that any longer. We leave the tendon be totally, and we do instead the dorsally based closing wedge osteotomy without touching the tendon at all. So we change the local mechanics, because if I do an osteotomy, a dorsally based closing wedge osteotomy, essentially I am rotating it and then lifting up. And so maybe that in addition to decompressing, inverted commas, the portion anterior to the tendon, I also change the mechanics and therefore the local biology for the tendon.
Sure. So my question was, fine, we are still probably 5 years behind the master.
No.
Now, if you have done all this stuff and the patient still complains a bit of pain even after 6 months, what do you think has gone wrong, or how do you deal with it?
Yeah, one of my fellows is just analyzing the data on the failure of this kind of surgery. If we do this kind of surgery, the recovery time is even longer. And in a paper using the Cincinnati approach to the foot to do all this that you described, the average time to return to sport was 35 weeks, 9 months. Okay.
Mm-hmm.
So, again, the most common cause for failure of well-performed surgery is anxiety to return to sport too fast.
Okay.
If they return to sport too fast, we have identified a subpopulation of patients who develop a very florid bone marrow edema in that area. So if they do, and you identify that, and you take an MRI, and you show they have bone marrow edema, then we put them in a boot, in an ACAS boot, and we leave them there for 4 weeks. They have to rest.
Okay.
If the patients are the typical now you worked in the UK, and so you know that the typical footballer in the UK has the average mental age of a 12-year-old boy. So if they do that, then I put them in a synthetic cast, okay? In a Scotch cast, because in this way they cannot remove themselves, and they are obliged to stay still. Okay? But it is 4 weeks in cast, and then they wait.
Okay. Thank you. Thank you so much for your time. Can I ask just one more small favor? There are a few questions which have been asked in the Q&A section. If you don't mind answering these, please, and then when you're ready, we'll say goodbye to you.
Now, let's see. Do I go into question and answer?
Yes, if you just go in Q&A, and if you can stop.
Arthroscopic tenolysis. Okay, one is arthroscopic tenolysis, any experience? Yes, I have experience. I don't do it any longer, simply because it takes me too long. Okay, it takes me too long. I'm never sure whether I've done enough. I do endoscopies, as in soft tissue endoscopy of the ankle. I started doing them in 1999-2000, and now essentially we have abandoned them. We've just had a randomized controlled trial accepted as a pilot study, accepted, where we're doing Achilles tendoscopy, tendinopathy associated either on its own or associated with PRP injection, and PRP doesn't make any difference. Do I do Z calcaneal osteotomy with insertion tendinosis? No, I don't do Z osteotomies. I do closing wedges, dorsally based closing wedge osteotomies. If you look at the literature, as I was saying, in April this year, we published our experience in dorsally based closing wedge osteotomies. Then what is indication to detach the tendon from insertion? At present, I essentially never do it. Dorsally closing wedge osteotomy, I've answered that already.
Okay, excellent.
Okay. Open, anything else?
No, that's fine. Fantastic.
No. Okay. Thank you very much.
Thank you so much.
All the best, and thank you for hosting me. Bye-bye.
Thank you. Bye-bye. Thank you.
Brother, be safe, man.
Bye-bye, brother. Thank you very much. See you, Anish.
If you just, thank you so much.
Bye-bye.
Anish, off to you.
Okay, let me just share my screen.
Thank you, Anish.
Of course. Share. Give me 1 second. Let me just maximize it.
Yeah, we can see it.
Okay. It'll be slightly different talk than Nicola. He's very smart, gives a large kind of scientific overview. Mine's going to be more practical. So peroneal tendons, kind of an overview and things you may not know. I mean, when you look at the peroneal tendons, I'm sure everyone in the audience is very aware of this problem and what they do for it. One thing that I will say, and Meyerson kind of gave us a lecture in Switzerland about 1.5 years ago, was that these don't do very well. I think if you look at your own patients and your own data, these are very frustrating cases, frustrated patients, and you as a surgeon, I become very disappointed in what we do. I used to think I had an answer for this, and I'm going to tell you I don't, and I'm going to kind of go through my thoughts, the research, and kind of how we can deal with this. So these are the basics. You know you have synovitis, you've got your tears. These bad things are obvious. Subluxation is probably the one diagnosis that's the easiest to deal with, because that we can fix. Everything else is throwing a dart at a wall. Revision, this, if you want to do peroneal tendon revision work, you should be prepared for failure and disappointment, 100%, because it's really hard to fix. So when does this occur? You can see this guy's popping his tendons. You get this traumatically. You get it from subluxation. That can cause peroneal tendon problems. Excessive acute excessive strain causing a tear, and then complete rupture from a trauma is very rare. The other things are chronic. They just show up with this problem. So you have to look at hindfoot alignment. Something that I kind of think, which I have not seen in the literature, is just objective laxity. I think objective laxity is probably the root cause for peroneal tendon problem in most patients that don't have any good reason for it. Because the tendon itself will not just degenerate on its own, become symptomatic on its own. It's like an osteochondral defect. Why does an osteochondral defect give you pain? If you MRI 100 patients, so many will have an OCLT. But why does that give them pain? Because either the defect is loose or there's mechanical overload from instability. Same idea for this, because so many people have peroneal tendinopathy based on MRI that are asymptomatic, which I'll get into. They may have autoimmune or just degenerative and idiopathic, but I will tell you that's what we don't understand. When we say idiopathic peroneal tendinosis, that means we're not catching or we're not understanding the underlying root cause for these people, which is kind of what Nicole has been getting into. There may be a metabolic issue, medication issue. That's why these don't do so well all the time. There's mechanical things. So hypertrophic peroneal tubercle is going to irritate the peroneus longus, and that's easy. You can see it right here. They have a large prominence. You can see the bump on their skin. You get rid of that. That helps them a ton. Subluxation is great. You can see here on the ultrasound, the tendon will flip back and forth over the peroneal tendon groove. And that's an easy thing. You can see it right here. It pops over. So that's a great test. So if there's any concern for intrasheath or normal subluxation, get a dynamic ultrasound, and you'll have your answer, and that we can fix. Standard MRI findings. MRI for peroneal tendon pathology is very difficult to interpret because there's multiple things you're going to see, and a lot of times it's incidental. So be careful getting an MRI and saying, that's your problem, I'm going to go after the peroneal tendons. You get tendinosis, this is bad. This is obvious. The cordis is easy to see. It's this tiny little black dot. So there should only be two tendons. If you see that tiny little black dot, that's probably a cordis that attaches to the lateral calcaneus. That can end up giving you pain because of space-occupying lesion. Gross degeneration, the gray area, shows obvious disaster of that peroneal tendon. You get that split tear. You can see the long arrow is the longest, and the two arrowheads are the brevis. That is split, so that's a split tear. It doesn't mean you have to operate, but it's just something you can find. C-shaped is probably the most soft call for a peroneus brevis tear. A lot of peroneal tendons look like that, and so if you operate on a C-shaped peroneus brevis, you're asking for trouble. Make sure that patient's extremely symptomatic before you go after that. Low-lying muscle belly, so you can see here that distal 1 centimeter of the fibula, and then inferior to that, if you see muscle belly, that is sometimes associated with a space-occupying type lesion. Synovitis can cause pain. So in those cases, you may want to excise that as well. This is the magic angle phenomenon. What that means is on a sagittal cut on an MRI, you get this intermediate signal as the peroneal tendons go that 45 degrees around the fibula. Do not make any diagnostic statements based on this image. I don't even look at the sagittal when I look at an MRI. If your radiologist is saying on the sagittal they see tendinosis, you have to ignore it. They should know about this phenomenon. It just, because of the angle and the cut, they always look gray. So it's not tendinosis unless you look at it on the axial. Subluxation is obvious. In this case, you see that it's obviously lateral to the groove. And so this is a great article that was done by Dr. Rakin and his team in 2016. I think everyone here should know this one. In short summary, 35% of patients had pathology on routine MRI. So you have to be very careful treating a patient that comes in with an MRI, says, oh, my medial ankle hurts, but I have the peroneal tendon problem. Why won't you fix it? And it's very frustrating to deal with these people. So many people have tendinosis, split tear. There's a lot of problems. Now, rupture and subluxation is different. That's not common. But tendinosis, synovitis, and split tear, they occur all the time. So the question is, why do they have pain? Conservative treatment is really, there's no data for peroneal tendinosis. For an acute SPR injury, there's some data. You cast them is better than taping. You give it to anybody that's not athletic. So I was making fun of Pradeep, but myself as well. I don't do a lot of athletics. You know, put me in a cast, see what happens. But in an athlete, you definitely have to operate. There's no question. Because the failure rate is pretty high. For chronic peroneal subluxation, there's no data. You can't really, you either say, go with God. There's no therapy. There's no bracing. There's nothing. They're going to subluxate. They're going to subluxate. You can give them a brace. But the problem is recurrent subluxation theoretically will cause chronic tears, and so we don't really advocate leaving chronic subluxation. Symptomatic, we always operate. For synovitis, you want to do synovectomy, repair the tendon, groove deepening, remove the tubercle, and then imbricate the retinaculum, which we'll get into. Now, historically, we always use 50%. That was our cutoff. If you have more than 50% of tendon disease, you have to do a tendon transfer. Now, biomechanically, a recent study showed you can even just tubularize 30% and they'll be fine. Mechanically, it won't tear. The truth is we don't understand what happens when we tubularize a tendon. We don't really understand what we're doing. It's not isolated the fact that the tendon won't rip in half is why we do it. The theory is that also that there's not enough viable tendon that's going to heal in the end and give some true function and has the ability to heal. But because tendon transfer is not a great operation in general for active people, we try to spare both tendons, that you don't have to transfer as aggressive as we used to a few years ago. So you can tubularize much more than you think. And so the number of 30% is hard to quantify in the operating room. What I say now, based on the study and my own experience, is that if there's enough tendon that you think you can tubularize it, it's not a wisp of tendon, save the tendon and tubularize it and don't do a tendon transfer. So you can salvage more than you probably thought you could before. Excise everything. That's synovitis. Excise everything you can. Tubularize the tendon, and I start proximal to the tear, and then I'll baseball stitch it and then end up distal so I have enough. I don't want to stop only at the level of the tear because I want to add mechanical stability to the tendon. I use nylon or PDS. I actually don't use any Ethibond or Vicryl anymore for tendons. I like PDS more. If you feel that your suture needs to be there long-term to provide structural stability to the tendon, then biologically this is not going to work, right? The whole point is to biologically supplement the tendon. Mechanically supplement till it biologically heals. So you should not be needing non-absorbable suture. And some people get a nasty reaction to Ethibond or Vicryl, a lot of inflammation. So PDS is probably your best tendon to use. I like 4-0, but you can use 3-0 if you want. And it seems to me that makes a much better outcome. I've talked to these lab guys out of the UK, and they've explained to me PDS is a great tendon, great suture for tendon. It causes a natural inflammatory reaction to get healing. I haven't looked it up more than that, but that's what I use, and it's been relatively okay. So the incision, just so everybody knows, distally you're going to hit the sural nerve sometimes. So just be very careful on making that distal aspect. Once you get through the skin, you're going to see the retinaculum. You're going to see it right here. And then you just want to do your tendon repair. You can see there at the end, there's the longest, and it should have a nice smooth appearance at the end. And that's the brevis tubularization. I'm not going to go through how to do a baseball. Everybody knows that. Key things you want to look for is a low-lying muscle belly. You may see that within the distal fibular groove and more distal. Look for that peroneus cordis on the MRI. These are things that if you don't excise are going to be associated with recurrence and continued pain for the patient. So in this case, you can see a low-lying muscle belly. You can see the muscle is actually distal to the tip of the fibula. That is not an anatomic normality. That has to be excised. And actually, for every case that I do, I excise the distal 2 centimeters of muscle off the brevis because I want to decompress that groove. In this case, you can see it right there. There's the fibula. And in here, you can see the cordis. You see it right there. It's attached. It's a small muscle attached to the lateral calcaneus. You have to excise that every time. Just peel it off the retinaculum, and then use your electrocautery or Bovie to make sure the muscle doesn't bleed too much. So now if I do this, if it's less than 70% viable, then I will do a tendon transfer. So I'll do a side-to-side tenodesis, assuming the other tendon is normal. You can use dermal matrix. You may have seen some of this graft jacket, or Arthrex has something called the Arthroflex, or whatever other market you have out there. There's couple articles, not a lot, that if you have a defect, you can just wrap this dermal matrix in there and they do okay. I've never done that. I'm not sure you can do that, but something to consider if you don't want to use an allograft of a tendon. It's the same concept. You don't want to do a tenodesis. In order to do any salvage, you have to make sure you have normal excursion of the proximal muscle belly. So this is a complete rupture of the longus. This tendon is disaster. You're not going to salvage this. It's garbage up top. Trying to salvage this with an allograft or a dermal matrix is a bad idea. In this case, you want to cut it and just leave the brevis, and you can do a proximal tenodesis if the muscle belly is okay, but a lot of times it's not. And I will tell you, in a non-athletic patient, they'll do just fine with one tendon. And Mafuli already showed this, right? If an athlete can get by with a single peroneal tendon, just the longest, there is no reason to assume that a normal person needs two tendons as well. So this whole concept that we have to have both and you have to do a graft if one is diseased doesn't hold any water. And so, and the thing I'll tell you that is because a tendon transfer doesn't always do well, especially if the proximal muscle is questionable. So if it's questionable, cut it and go, and don't worry about it. The most important function, most commonly, and I understand what Nicola said for the Achilles, but for most patients, it is the peroneus brevis that's the most relevant muscle that you want to save. Now, if they have a flat foot, then that's different. But normal anatomy, cavus, you want to save the brevis. So you can see in this case, the brevis is destroyed. It's completely gone. This is the sural nerve you can see actually crossing in my incision. So you have to be careful sometimes. It may cross distally. So I do a proximal tenodesis, and then distally, I'll take the longest and suture it into the stump of the brevis. So cut it proximally, cut the longest distally, suture it into the brevis, because my goal is to restore the function of the brevis more importantly than the function of the longest. You could just do a side-to-side tenodesis as well. So you can preserve both function. That's up to you. If it's a cavus foot, always think about that. Think about your lateral closing wedge calc osteotomy, and very, very low threshold to do a dorsiflexion osteotomy first metatarsal. You can see in this case, we do the osteotomy. I got rid of the thickened tendon. This is the longest. And then in order to do the tenodesis, I will pull the longest as hard as I can, and then tension the longest to the brevis and a cavus foot, because I want to get some pull. In a non-deformity, I'll just do a side-to-side tenodesis first, and then I will excise the disease portion to maintain the normal length relationship. But if there's deformity, I want to try to correct it. So that's what I'm trying to show here. Groove deepening. This is a little bit controversial. So we know that it decreased the pressure in the perineal groove, no question. It's ideal for subluxation. I think we all agree with that. It may minimize recurrence of synovitis or tear. That's where the controversy is. Some people advocate doing this for every single case, no matter what. And it's something that you have to decide on your own if you think it's important. The way I look at it, if I have a low-lying muscle belly, a peroneus cordis that I took out, if I excised one of the tendons, I've done a groove deepening, quote unquote, by definition. I've decreased the mass within the perineal groove, and I don't have to do a groove deepening. But if I have a lot of synovitis, I salvage both tendons, I didn't excise anything, in that case, a groove deepening makes sense because that may minimize that pressure. But if you're excising a large mass, you don't need to do a groove deepening, in my opinion. It's your choice. There's many ways to do it. However you want is up to you. I don't like the cortical window or the drilling. I use a burr or a power rasp so I can dial in the amount of groove that I have. It's very effective. Nothing will pop back. The only downside is that you remove some of that smooth surface. I just put bone wax on there. And I will tell you, I've never had a person have a problem with scarring of the tendon along the bone. If you put sufficient bone wax to smooth it down, they do fine. So this is perineal subluxation. You can see where it lies, and then it easily will pop anteriorly. You can see here, the tendon pops back and forth after I cut the skin. So it's pathologic. Cut the tendons, pull the tendons anteriorly, very important. You can see the groove here. And then I just use a rasp, go back and forth. And a power rasp is probably the best way, though a burr works really well. And about that distal 2.5 centimeters, you don't want to get into diaphyseal bone and get a nice groove. Bone wax is critical. And then you can see when you're done, the tendon should easily glide within the groove without subluxation when you're done, without perineal tendon repair, reticular repair. You can use drill holes to do this, or you can just use, if you have some of the fibroretinacular ridge left, you can use that, but it's a pants over vest. And then now you get a nice imbrication, and then you can use figure of 8, as we've shown here, to complete the repair. This is critical. Revision is the hardest part. So if you operate on them and they fail, which I will tell you, and if you look at some of the data out there, it's about 20-25% of the time, peroneal tendon surgery is not satisfactory. So FHL transfer the base of the fifth metatarsal. It does recreate the dynamic reversion of the peroneals, does not recreate plantar flexion of the first ray, and kind of stinks. They will get 4 out of 5, 5 minus out of 5 at best. They are not active after that. So a lot of people think about the graft. It's been published by Meyerson. Seelan has published this as well. There's kind of concepts that you have to have proximal muscle that's viable. So an MRI of the leg is important, not of the ankle. You want to see if there's fatty infiltration of the peroneals. If there's fatty infiltration, a graft's not going to work. Go ahead and do an FHL. But if there's not fatty infiltration, do an allograft, and it's actually very nice. So for the FHL, you go medial, you want a long harvest. You can see here, when you pull it, you have the cross tendinotic slips to the FDL. You have to slice it so that you can't just rip it out because you'll get stuck. So you have to make a formal approach. Laterally, this person had infection, 3 surgeries. The muscle is gone. There's nothing here, so you excise all of that. And then you take the FHL laterally. You can just go right there. The retinaculum is right there. You pop it, pull the FHL laterally. You can see you need a very long harvest for this to work. Now, in this case, there was an infection, and I'm a big fan of this neo-tunnel creation for Achilles allograft for the peroneal tendon. This is just a Mo impactor, but I use it to create a new tunnel, because if you cut the skin, it's just scar. And if you try to put the allograft in, you have tension and it's not going to work. So then you drop the graft in your neo tunnel from proximal to distal, and you evert this as hard as you can. You can use a suture anchor and then suture to whatever tissue you have left distally, and that's what it looks like. Or you can drill it, put it through a bone tunnel if you wish as well. They'll make sure their tunnel is small because you want to fracture the fifth metatarsal. 6 months post-op, this lady has active eversion, but again, it's about a 4 out of 5, 4+. It's not great. Allograft, this is a different guy. So now you can do allograft. You can see I have excursion and viable proximal muscle. He's a young guy. And so at the end, we did an allograft. You can see I have proximal muscle excursion in an allograft situation. If you have both muscles viable, you can suture it to both. But in the end, you're only doing a graft for one of the tendons. Yes, you can allograft reconstruct both the longus and the brevis. It's a lot of work. It's a lot of tissue. And I will tell you that's not a bright idea. Graft one if you can and take the brevis in most cases, unless they have a flat foot. So the newer concepts, just to summarize this, look at the biomechanics. Think about ankle instability in every single peroneal tendon patient. They may not complain to you that their ankle is giving out because they're having so much pain. So almost everybody's getting a rostrum now that has peroneal tendon disease in my hands because I'm examining them and being much more sensitive to their instability. Because the thought is that if you have chronic instability, your secondary stabilizer is your peroneal tendon. That is overworking, and that's why they're getting symptomatic peroneal tendon disease, all trying to minimize my recurrence. There's no data on this, but it's something I think everyone should think about. For tears, we used to say 50%. Now we're saying you can salvage much more. And so unless the tendon is complete garbage, basically you should tubularize it. And if it's really bad, do a groove deepening. There's nothing wrong with that if you really think the tendons are not healthy. If one tendon is garbage, a tenodesis is still a very good operation in that case. It's not great, but it's good. And then think about your deformity. It's not just I'm going to save the brevis every time. If they're flat foot, you want to save the longus. If it's a cavus or if it's a normal patient, save the brevis. And allografting in the setting of one good tendon doesn't make any sense to me, though you can if you want to get aggressive. But again, in an athletic patient, they do fine when you do a tendon transfer of one. So it may not be necessary. If both are gone, get an MRI of the leg. If the muscle is healthy, then do an allograft reconstruction of the brevis most commonly, or the longus if it's flat foot. If there's no excursion or fatty infiltration, in that case, an FHL transfer, unfortunately, is your only option. And then subluxation is obvious, nothing new. Always do groove deepening with your surgical reconstruction. Thank you very much.
Thank you, Anish. Fantastic talk, and as usual, covered almost everything on peroneal tendons. I don't think so you have left anything. Balwinder, any questions?
Yeah, I think Anish has covered it almost everything has been covered. So, what about the couple of things about the superior peroneal retinacular repair? In subluxations, do you think it can work alone without any other procedure, without groove deepening or something? And you have to have you ever used a suture anchor to anchor having not found the SPR attachment on the fibular rim, the margins? And have you ever anchored the posterior part of the retinaculum directly onto the bone using anchors?
So fair questions. I've never done for subluxation, I've always done a groove deepening. I bet you might be able to get away without doing a groove deepening, but in this country, that's almost considered malpractice. So you can't try it on someone, honestly. Given the low morbidity of a groove deepening, it's so easy to do. If you just do it with the burr, and the difficulty of having recurrent subluxation, that I've never tried it and I don't think it's necessary, but I don't know the data on it because you can't do that here. For the retinacular repair for anchors, I've never used an anchor because for me, if they have no tissue, if I made a mistake on my dissection and I cut the fibrocartilaginous ridge off by accident or it's not there, I'll do drill holes. But a suture anchor is absolutely a viable option. But drill holes are really easy to do and doesn't have that excessive knot. But an anchor should be fine too. If you want to use an anchor, you can just go proximal lateral, anchor it in and use that. But ideally, you want the retinaculum to be deep to that lateral fibula on the medial side, actually. You technically have to put your anchor in on the deep side to get that same mechanical effect, and I've not done that. It's got to be a little bit more difficult, and then you'll have foreign material there. So I would say if you get in that situation, I would recommend drill holes, 4 drill holes or 3 drill holes with the K-wire as opposed to a suture anchor because it gives you that better mechanical placement of the retinaculum.
Okay. How about the laxity? I mean, you mentioned that you believe that many of these patients actually the reason for peroneal tendon problems is a ligamentous laxity. So there are patients where you can actually elicit that they are lax at other joints. While you say that it's possible that you cannot elicit the laxity in other joints, but you can still have problems. But in case you can elicit the laxity, would your treatment differ for any of these patients?
Do they have like global ligamentous laxity is what you're saying?
Yeah.
Yeah, it's a great question, Bobinder. If they lax on both sides and their peroneal tendons hurt, the argument to tighten them up doesn't hold as much water. 100% makes sense. But because it's a belief system, because I have not figured out why that side hurts, and we are not as sensitive. So let's suppose they're lax on both sides, but the affected side is 15% more unstable. You can't feel that. We can't examine that. You have no idea. So theoretically, then, my mind, which is not based on science, is that if they're coming with peroneal tendon pain and they're lax, the laxity for any repair of the tendon is gonna be a detriment to it, even though they were born that way, right? They were born that way. It's fine, but it's like the same thing like a cavus foot. I had a cavus foot, but now my peroneal tendons hurt. Why do you have to reconstruct my foot? Because the reconstruction is not making them normal. The tendons are diseased. You're going to clean out the tendons, debride them, and you want to give them every mechanical advantage to heal. It's the same concept that we do for a cavus foot. And I have 2 cavus feet exactly the same. One side has a problem, one side doesn't. Why don't you just fix the tendon? Because you can't. The tendon is not the same underlying structure biologically that it was 30 years ago. And so for that reason, I still will tighten them up because I don't think we're making these tendons back to normal. And
so sorry, can I just ask you on the same question as Balwinder, because I had the same thing. So even if they do not give any history of instability of the ankle with only a peroneal tendon symptom, so your examination is tenderness on the peroneal, the MRI shows your peroneal tendons are torn, you would still go ahead and stabilize the ankle and do a brostrum?
If they're unstable on exam, if they have mechanical instability, not if they're not unstable, right? So yeah, if they're mechanically unstable And I understand they don't say they're functionally unstable. They say, my problem is pain. It doesn't give out. In my mind, I think that instability is part of the reason why they have the problem and why peroneal tendon stuff fails. So I will do a rostrum. And it's controversial. I'm just something I thought of in the last couple of years. Because peroneal tendon surgery, if you look at all the data from people that publish honestly, is terrible. It is not a reproducible operation.
Correct. It's quite interesting. I'm doing one tomorrow morning.
Good luck. I hate it now. I absolutely hate these patients. I hate dealing with the problem. They complain all the time. And I think what Nicolo said is a good statement. It takes 7 months, 8 months. They are just angry at 5 months, 4 months.
So drawing the same corollary where Nicola said for Achilles tendinopathy, especially insertional, he does a Kelly cake. So he does a closing wedge osteotomy. So suppose you have a peroneal tendinopathy with a mild cavus, just correcting the cavus and leaving the tendon, would it not make sense? Just doing a closing wedge or a lateral shift, you mean to say. Lateral closing wedge on the calcaneum and leave the tendon.
It's not a bad concept. If the tendon is not totally disaster, right? If it's just inflamed.
Correct, of course.
Yeah, it's not unreasonable. I don't know who's done that. I've not tried that. It's so not an unreasonable idea. It's slightly different for the calcaneus because you're actually moving the prominence off of the tendon. So it's a little bit more direct for the calcaneus, but the concept holds for the peroneals for sure.
Correct. Okay. Questions from participants. What is the most common complication of peroneal tendon repair in your experience? From Shantanu.
Persistent pain. That's it. Persistent tendinosis and post-operative evidence of a tear, which is the most frustrating thing to see. If you go in for synovitis, you go back, and the most common complication is pain. You get an MRI at 6 months. It'll show a peroneal tendon tear where you went in and operated. Now it's your fault. I don't know what the heck the MRI looks like post-op, but it's garbage. So that's the number one complication.
Okay. Question from Muhammad Mekhamar. Hi Anish, if asymptomatic peroneal tendon subluxation in young person, do you treat them?
If non-symptomatic?
Correct.
Yes. And it's a hard discussion to have. I go back to the fact that a peroneal tendon groove deepening and restoration of stability is very predictable. And if a 20-year-old has subluxation, although we have no longitudinal study, there's not one study that I know of that says you have subluxation at 20, you're guaranteed to get disease at 50. Mechanically, it must happen. And so if they wait 10 years and now they have peroneal tendon disease, it's very hard to deal with. So I will tell them, you should get this fixed for the theoretical reason, knowing that I may make them worse. But I believe in and if you can minimize the damage to the tendon itself, you give them a better lifetime option.
Okay.
But it's a gamble, but I advocate it.
Sure. And probably the same thing, snapping peroneal tendons without subluxation but painful. What is your treatment, or is it still the same?
So painful intra-sheath subluxation, I will operate. Same thing, groove deepening, synovectomy, retinacular repair, but non-painful intra-sheath subluxation, I don't operate because they're not snapping over the groove and having that mechanical damage. There's a big difference between true subluxation that's asymptomatic and intra-sheath that's asymptomatic.
Okay, one more from Dr. Subhash Burad. Severe peroneal tendinopathy where both tendons are severely damaged with ankle instability. What will be your treatment of choice? Will you go in one stage with tendon transfer or two stage? What will be your choice of treatment for ankle instability in this case where both tendons are severely damaged?
So very, very good question. In that case, if I have severe damage, both are garbage, unsalvageable. I get the MRI of the leg. So the ankle MRI shows both tendons are gone. If you're lucky enough to figure that out beforehand, then you get the leg MRI and you see if there's muscle viability. If there is, I'm going to do a graft. If you get in there and you didn't anticipate that, you get in, you're like, oh God, both are gone now. What am I going to do? Then I will intraoperatively check excursion of the muscle. If one of the muscle bellies is viable, I still will do a graft. To reconstruct. If both are gone, I'll do an FHL transfer. But in the case of both, for the instability, I won't do a Brostrom anymore. In isolation, I do a Brostrom with the internal brace, but I'll do an Evans with whatever stump of the distal brevis I can find. Because if both are gone, the ability to evert is shot. An FHL transfer is no good, and a tendon allograft is unknown, even though some people publish it does great. The truth is, nothing does great if you have a garbage segment of tendon graft. So I'll do an Evans in addition to a Brostrom in order to ensure that they have subtalar and ankle stability, and then I will do whatever tendon reconstruction I have to do, whether it's an FHL or a graft.
Okay. One more question was there. Do you do the MRI regularly to assess for excursion?
No, only if I get an MRI and both tendons look very damaged on the MRI, then MRI for us is not dynamic, so I can just see the quality of the muscle. If it's a revision, I do get, if a revision, more lower threshold to get the ankle MRI to see. You could get ultrasound to assess the viability of the muscle and mobility. We don't routinely do that, but that's your other option to see if there's mobility. But usually we just get a leg MRI to see if the muscle is fatty or normal. And if it is, then we know we can do a graft on these people.
Okay, excellent. Balwinder, any questions or can we move forward?
Yeah, just one more thing also. Just wanted to ask Anish, if the patient does not have a low-lying muscle belly and does not have a quadratus, then is there a clinical entity or a radiological entity of a shallow fibular groove? Does it exist, or are there different grooves where you think the deepening is needed, or it's just that you do it in every case?
Listen, that's a very fair question. I don't know the exact answer. I don't really believe in the shallow fibular groove as much as other people do. I looked at every fibular groove I've ever operated on in the MRIs. No one has a convex groove. Okay, God didn't make us like that. That's almost impossible to have. So you can have a flat groove or a very concave groove. If there's nothing there, nothing to excise, and they have a relatively flat groove, then I will do a groove deepening. But I make that decision in the operating room, kind of like you said. If the groove is really deep, typically they're not coming to you with the problem. I mean, the truth is, for every radial tendon surgery I've done, the groove is never deep. It's just not. Now, maybe those people are the ones that are showing up. So I think if there's nothing to excise, no matter what the groove looks like, I make a big, deep groove. I lowered my threshold recently in the last few years to do a groove deepening if I don't excise anything. But there's all the studies talking about what kind of grooves there are. But if somebody has a flat groove and you take out a large cordis or you take out a large low-lying muscle belly, I don't think you have to deepen that groove. I don't think the groove in and of itself is the problem, if that makes sense. I think you have to look at the whole picture.
Yeah, sure. Got it.
Excellent. Thank you so much, Anish. Great talk as usual. Can I ask you to stop sharing, and Balwinder, if you're ready with your cases?
Yeah, sure.
Thanks, guys.
You're sticking around, right?
Yeah, man, I'm here for you, brother. I never leave you, man.
Thank you so much, Anish. I knew you would.
So I'm trying to share my screen at the moment, and I find that when I'm clicking on the shared screen, then I don't get the second tab that you get to share. It's not green. So,
Dr. Jayanta?
I got it.
Yeah, okay.
So we're going to show you a couple of cases. The first one is a 20-year-old male. Oh, that's a peroneal tendon. I'm sorry. Let me go back to the calcific Achilles tendon. Sorry about that. A bit of a fiasco there. Let me quickly go back to my presentations. So this is a patient, a 40-year-old male who has pain and swelling back of both the heels.
You'll need to, Balwinder, sorry, Can't see your other PPT. Balwinder?
Yeah.
We still
We
see
can-
the same one, brother.
We can see your same peroneal tendon PPT.
Okay, can you see it now?
Yes. Now you can.
Oh, sorry for that. Some technical issues. So 40-year-old male, pain and swelling back of both heels for the last 5 years before presentation to us. No known comorbidities. Not an athletic kind of a person. Presented to us with this clinical picture. So significant bony bumps at the back of the tendons, at the back of the heels on both sides, more painful on the left side. Significant tenderness, pain he described as could not walk more than half a kilometer. And the pain would increase significantly after walking half a kilometer, making him to rest intermittently. And the level of pain he described was 7 on 10 with that clinical picture. So what would be your approach to this kind of a patient? These are the x-rays. You can see a significant amount of calcification at the insertion of the tendon. So something like a calcific Achilles tendinopathy at the insertion. And that's the left side. So what would be your approach? May I ask, maybe Anish, how would you approach this kind of a situation? And then Pradeep.
Anish.
So if it's a young person, you just want to make sure there's no, if you see both the bottom as well, the person has a lot of enthesitis, so you may just want to consider see a rheumatologist, not to surgically fix it, but because they have massive enthesopathy in a young person. It's unusual. So maybe they have some, seronegative spondyloarthropathy that would cause that. But that aside, if I'll talk from Mafuli as well, because I know how he thinks a little bit, he would say that this is not going to work, metabolic, all that stuff. So non-surgical for this, waste of time.
Yeah.
Either is lift and live with it, or do surgery. The problem with the Zadig osteotomy, which is that closing wedge osteotomy, you have to take out a huge chunk to decompress this guy's calcaneus. I don't think for this case that's going to be effective. If there was less calcific, the Zadig osteotomy would be better. So for me, it's a longitudinal posterior approach. Excise all that tissue. The problem is this guy, you get MRI, but a lot of his tendon is gone now. It's calcified. So for most of my insertional, I'll do a gastroc recession to take tension off of it as I repair it down. I think that's an important part of this. If this was very mild, you could just do a gastroc, but in this case, you have to take it down. But you may end up with the situation where there's nothing for like 3 centimeters of tendon left. So in this case, I would be prepared with an allograft to reconstruct this tendon because he's young, right? He's a young guy. So you have to be prepared, right? Or how old is he?
He's 40.
Yeah. So I would be prepared with an allograft, or you should be prepared with a tendon transfer in your mind because you're going to excise most of this tendon because that's gone.
Yeah, okay.
That's the concern.
So Pradeep, what would be your choice?
So the same thing, I think what Anish has already said, just go back to the x-rays, please. So yes, so same thing. So remove all the bony calcifications, the haglins, the posterior calcifications, the calcification in the tendon, and then I would assess how much is a gap. If it is too tight, if the gap is sufficiently less, and if you can get the tendon, the tendon Achilles back onto the calcaneum, I would reattach it, but I would be prepared to do a tendon transfer as well, and probably allograft is not available where we are, so I would be prepared for an FHL as well in this case.
Right. All right, so we did an
If you don't
MRI.
have allograft, then a turn down is a good option.
Okay.
If you don't have graft, we have a luxury here, but then a turn down, because you don't want to lose the function of the Achilles in a young guy. So then be prepared to do a turn down, which is a huge whack, but that's the other option.
Okay.
Yeah. Okay, so we did an MRI, obviously, which showed the tendon was degenerated in large areas along with calcification in the substance of the tendon. So significant areas of degeneration were there. Then we went ahead and obviously did a surgical treatment because the patient had already taken a lot of conservative treatment for the last 3 years, and he had taken every possible conceivable kind of physiotherapy. He had a couple of PRP injections. In that situation also, somebody did an injection about 6 months before he presented to us, and it only increased the pain. So that's what we did then. Finally, we did. Are you able to see this video?
Yeah.
So we did a midline incision, directly entered into the middle of the tendon there. Did not do any, not supposed to do any subcutaneous dissection. And when you are full thickness into the tendon, use retractors. So we detached a large part of the tendon almost entirely from the posterior surface of the calcaneus, and a large part of the tendon had to be excised, obviously. The Wheatlander can be used deep only when you have completely split the tendon. So a large chunk of bone then excised. Maybe you could argue that a little bit more was needed. A bone excision was a little bit more. Then we did an FHL transfer because we believed a large part of the tendon had been sacrificed. Deep fascia, you see the FHL tendon there, dissected towards the medial malleolus, it out into the wound and tag it with Vicryl sutures, and then you use the beach pin that we use in the ACL surgery to anchor the FHL onto the calcaneus. There's a beach pin tunnel created, and the tendon is passed into the tunnel created for the receipt of the tendon. And as it is inside, then a tenodesis screw, a bioabsorbable screw to hold the tendon in place. So that's quite a strong fixation. So you can lift the FHL without any stress. We did a tendon debridement, and then obviously we could see earlier that it is quite a significant amount of tendon will have to be. But still there was a significant amount of tendon remaining. So we did anchor the remaining tendon back with a couple of sutures anchor on the backside, and then repaired the tendon onto itself. So these are these post-op images. On one side has been operated. Post-op movements started to mobilize the ankle at 3 weeks, and you can see a significant good range of movement at about 6 weeks down the line. He has been exercising well, and significant relief was there. But obviously, this kind of disease, you cannot promise anything to the patient. So your comments on this treatment? Anish?
Oh, I think it looks good. Surprising that you had good tendon, but the MRI shows that. So I think it's a good option. And in some cases, if I have enough tendon, because I do believe what Mufuli says, the FHL does cause some morbidity. I've been much more aggressive with just doing so if that was me in this case, I would have done exactly what you did, but not the FHL part. I would have done a gastroc as well to take the tension off and repaired it with the speed bridge technique, which I know is expensive. We do it here, obviously. But I do think you can do a speed bridge type technique with cheaper than the Arthrex will actually get it for you if money is an issue. But that suture anchor, that very large footprint fixation, I think gives you a much better tendon to bone apposition and better healing, and allows you to get away with doing much more debridement than we used to before.
Okay.
So I would have, I haven't done an FHL, I'll be honest with you, in like 3 years.
Okay, so you left it for specific reasons. Do you think patients do have problem after an FHL transfer? If a patient is non-athletic, can still have a problem with an FHL loss?
Yeah, so it was a guy that I did he was chronic Achilles rupture, 55-year-old former soccer player, an older guy, but he had a neglected Achilles for 1 year.
Okay.
So I did an allograft with an FHL. Achilles worked fine. He was pissed that he could not get that push off barefoot. This guy was mad as hell. Mad. And then, Nicola's always been in my ear for years now because I've known him for a long time. And and you look at all the data on the FHL doesn't do very much in general. So for a non-active person, FHL is fine. For anybody else, I think younger, I tried just to spare the Achilles and do it. And I will tell you, a decade ago, I was the opposite. If you came into my office 10 years ago and had Achilles tendinosis insertional, I just basically whack the Achilles tendon off, do an FHL, and walk out of the operating room. And they did fine, but for walking, they could not do much more.
Okay.
And I think the speed bridge allowed me to get that proper Achilles bone footprint and a stable fixation, so they don't get that recurrent tendinosis. And the gastroc has helped a lot. Those are the two things that have changed in the last decade for me. I don't, unless the tendon is non-salvageable, I won't do FHL.
Just a question. I think I have not added, if I have a decent apposition of the Achilles tendon and I'm not really pulling the Achilles tendon to get a bone apposition, I've not added FHL at all. Only like I have a case which I'll show you where I cannot get the two ends opposite with like complete plantar flexion, then I would do an FHL. So that's one point. But while you're there, I wanted to ask Anish. Anish, you said when you try to oppose it, if it's too tight, you do a gastroc. You do a separate incision for a gastroc recession, or you just extend the whole incision?
Well, I make a small separate incision at standard musculotendinous junction, and I do it almost every time. But you got to understand, in the States, the guys Bohan, Anderson, and the group out of Seattle, and I was in Michigan for a long time, we talk a lot about the gastrocnemius contracture as the cause or part of pathology for this. So I'll examine everyone. If there's even a subtle silver scroll that's positive, you're going to get a gastroc, because I always have to ask myself, why do they have this problem? And I don't think we understand it, but if there's some biomechanical thing, I'll do a gastroc recession. Plus, it takes tension off my repair, so I can put it back down. So my threshold for gastroc in this condition is like none. I almost universally do it.
Correct.
Maybe not appropriate, but that's what I do.
Balwinder, what do you think? Means in India we are so lax, and we had this talk I think last week as well about and Karthik was there as well, where we have so much of dorsiflexion, like that getting a Silvis coil tightness in even pes planus and other stuff is quite rare. So for Achilles tendinopathy, doing a gastroc, I'm just a little bit worried, but it makes sense. Balwinder?
Well, it does make sense, theoretically speaking, and by the literature that we see and some people's opinion, as Anish is saying. But I've done very limited gastroc recessions in Achilles tendinopathies per se. But as you say, because our patients are not really tight. But obviously, as a long-standing patient, the Achilles is going to be tight. I believe we are not adding enough gastroc recessions. Maybe.
So
look at it. Yeah.
Great. Next, you have one more case.
So I think we are short of time. I have another, but do you want to take up, because otherwise you will not be able to speak?
Okay, I have few cases, quick rapid fire answers from both expert faculties. Okay, can you see my screen?
Yeah, brother.
Great, thank you. So let's start with this. 65. This is one case which I did only last week. 65-year-old male diabetic, giving me a sensation 4 months back, and he had the limb is gradually getting worse, and finally came with his son with this X-ray. Anish.
So it's my gut is it's an insertional calcific Achilles tendon rupture.
Yes.
And so he's 65, diabetic. So the different scenario than everything else I talked about. In this case, I would make that small, in a diabetic actually, I make a paramedial, I go medial. Elevate the Achilles off, excise all of that you see. Don't even worry about the ruptured tendon. FHL transfer only, walk out of there. I'm not going to try to do anything else on a 65-year-old.
Okay. Balwinder?
Yeah, I would agree, because diabetics with an Achilles tendon calcific avulsion will be very difficult to hold back down there with anything. So I would also at least add an FHL transfer and look at it when I open it, whether it is repairable, and bringing it down back after obviously excising the entire bone on the back of it by midline incision.
Okay. So, but you would try to repair plus an FHL, while Anish is saying only an FHL.
I would do both. I would try to repair and do an FHL, or definitely an FHL. Yeah.
Any investigation would you like pre-op?
You want to rule out neuropathy for sure, and then that's for counseling and prognosis purposes. I mean, if a patient is neuropathic with that kind of an avulsion, then holding it back on is going to be extremely difficult, I believe.
Anish, you?
I assume everyone's a neuropathic. So I don't trust these diabetics. I just get MRI just to make sure I'm not misdiagnosing it or over guessing it, but I'm pretty sure it'll show that it's completely popped.
So exactly. So I got an MRI done because two things I wanted to know. One was how much is the gap, if there is, because it's 4 months. So you want to know if you can do a primary repair or not, and how's the status of the tendon. So here you can see the gap was actually only 1.2 centimeters, around 4 centimeters from the insertion. Okay. So 1.2 centimeter gap, 4 centimeters from the insertion, and a little bit of tendinosis. So anything to plan? Any change of plan, Palvinder?
No, same thing. It's going to be a bad tendon. Once you enter it, you're going to be debriding it a bit, and you will end up with more gaps. Then possibly might be difficult to kind of bring it down even. So an FHL transfer for sure. 65-year-old diabetic patient.
How about conservative?
So you can put them in an AFO and go with GOT, carbon fiber AFO. Go with GOT. That's very reasonable option too, because you're not losing anything.
Exactly. Balwinder?
Yeah, I mean, you can counsel the patient if he can live with a bit of a limp and a functional problem. If he's happy with that, you may not touch it. But
okay,
people will not be happy. But if he's happy, just leave it.
Sure. Okay. So anyway, he had already made up his mind that he wanted surgery. So we've discussed all this. TA repair with Haglund's. Debridement, TA repair, VY-plasty or Haglund's, or straight away FHL. So Anish, choice 4?
Me 4. If he was younger guy, 45, 50, not diabetic, I would do number 3. But
okay,
this guy, 100% FHL, don't worry about the tendon.
Balwinder 4 or 3?
No, 4, I would say 4.
Okay, excellent. So this is where, when I opened it up, here you can see that's your a little bit of part of remnant of the Achilles tendon remaining, but this is the proximal part, this is the distal part, that's the big bump there. Here you can see that this is the knee end, the foot end, that's the Haglund's and everything excised. This is after debridement and the whole tendon, whatever the tendinosis part was there, that's been cut, and a huge gap was there. So initially I tried to salvage it and see if I could do an end-to-end repair, but every time I was trying to take a Kessler's or modified Kessler's, it would just cut through. So just went proximal, had a big gap, finally did a FHL straight away, and just did a side-to-side tenodesis for this shaft. Okay. Next one. Any questions or comments?
No, I think with that much of gap in the diabetic and FHL was the treatment, I think. Treatment of choice.
Okay, next case, 58-year-old lady, history of again giving way sensation 2 weeks back, difficulty in walking and limb. This is the X-ray. So similar type of stuff, okay?
Yeah, but non-diabetic.
Non-diabetic, of course non-diabetic.
And acute.
And acute, 2 weeks. Yeah, 2 weeks is acute for India.
Ah, that's perfect. This
okay.
You can see.
Yeah, so anyway, she finally decided to have surgery. You can see here, that's the tendon, clearly avulsed type. So you remember, Anish, we discussed, we see a lot of these kind of stuff. I have not seen many young athletic TA ruptures compared to the tendinopathic ruptures. You know what I mean?
Yeah, you were telling me. It's weird.
Yeah, but that's what our practice is, and I think Balwinder would agree with that.
Yeah.
Athletic person coming with a TA rupture is uncommon than these kind of cases. So anyway, she had this, opened it up, and I repaired this. Anything you want to say?
I would have taken out a little bit more bone. Well, only thing I've learned over time is to make my incision more distal.
Okay.
To get that curve out. You know that posterior aspect?
Yes.
So my incision is really distal to smooth that down. I don't know if that makes a difference.
No, so I had made actually a distal. So this was the initial photo which I wanted to just take of the tear. But I take a point. I could have gone a little bit more. What I say is now I almost make like a baby's bump, like a smooth top.
That's correct. That's the difference.
So you did debride the tendon because the tendon doesn't look that good in the.
This is the initial. This is not the after the debridement. This is just when.
So once you debride it, the gap must have been much more for the suture anchor to hold. It must have been a tight repair. And then this anchor, the direction of the anchor is not that great, you see. So it's not where the ideal location in the direction of the anchor is not ideal.
So would you had like to go a little bit more posterior and a little bit more like this horizontal?
Yeah, correct. So a little bit more posteriorly.
Yeah.
Here. And the direction of the anchor a bit more parallel to the floor, maybe does make a difference. And once you debride it, I mean, after debridement of this tendon, I don't think you would have had the gap, which would have required a VY at least to bring it down.
Okay. Anything else?
Looks like a bad tendon to me. Yeah. No.
I would have definitely done a gastroc here for sure.
Sure. Okay. So she was. Yeah. Go on, Anish.
Instead of a formal VY, a gastroc, because I bet you that posterior tendon is okay. The anterior half third was shot, so that's probably why you had something to attach. But a gastroc, like Govinder said, or some sort of deep way to get more length. And then again, I don't know if the speed bridge is more expensive, but it definitely allows you to get a much stronger fixation for crappy tendon as opposed to an anchor.
So if I was to use a speed bridge in this, I would have to probably pay from my pocket for the surgery.
The hell with that then. That's not going to happen, man.
Exactly. So anyway, so I put him in a cast in equinus for 4 weeks, walker boot for 6 weeks with wedges, where the wedges come out every 2 weeks, and then gradually range of movement exercise, walking with heel raise. That's my usual protocol. So she came 2 months post-op, increasing pain, mild swelling, mild limp, sent her for physio, said no, you'll get better because of the wasting. And she came back again with no, she's limping. Okay, so finally got an x-ray done. That's the x-ray.
Govinder was right.
Yes, I know.
He just pulled out, right?
Yes. Now what do you do? Now what do you do?
After you go to the bathroom and wipe your pants? Shit, man. Go back in.
Balwinder.
Let Anish take it out. I'll send it. No, I will ask for an opinion, Dr. Anish. Your opinion.
That's what. Yeah, go on.
I mean, it sucks and it happens, to everybody. So I know just making fun of your case because it's yours. We've all had this. So in this case, you would revise it for sure, but definitively you would do FHL at this point. To try to revise that again, doing the same thing with that quality of tissue, her bone may suck, whatever it may be. I would definitely do an FHL. And in general, I used to do 1 suture anchor for my Achilles. Then I started transitioning to 2. I think 2 is biomechanically much more logical than 1. Angle and all that is true, but I think 2 makes some sense. And if I had to revise, I would take the Achilles back down 2 anchors if you don't have a speed bridge, and then an FHL for sure, because that actually acts as a functional internal brace to the tendon. Therefore, your Achilles repair is secondarily held by the FHL as well. So there's not as much tension on the repair. And then 100% do gastroc in this case.
Okay. Balwinder, if you can just keep an eye on the Q&A or chat if somebody has any question, please. Is that okay?
Yeah, I'll do that.
Thank you. So, Balwinder, what would you do? Well, Indian patient, Indian Madu patient.
Yeah, I mean the same thing. Obviously, when you have to go back in, remove that anchor.
Okay.
Do a lengthening, debride the tendon again. Do an FHL. That would be the choice, right?
Okay. Fine. What I did was I told them that she needs a revision and all this stuff. She needs a reattachment and stuff. And doc, he said, "Doc, what if we just keep a plaster? Just continue and see how it goes." Okay. So I put her continued with the cast because I said what I would do now, I could do 1 month later as well and see. So put her in the cast for 4 weeks. And after that, gradually mobilized and then physio. And this is a video almost 4 months after the primary surgery. Sorry, this video, I don't know why my laptop works. She was able to even walk on her tiptoes.
What the hell?
Yeah. So
It goes
sorry.
real slow, man, like a turtle, though.
So,
No, my video, I don't know why the video
I know.
formatting is there, but she could actually walk tiptoes finally after like 4 months, even after the surgery, where I've not done anything. I just left it like that.
So what do you think happened, man? Like, what is the point of our surgery then? Do you think? So it's very good. It's impressive, and I've seen this too. Neglect on our part lets the body do whatever it does, and clearly that anchor is not holding the tendon. No question.
Correct. But I think by the time this came out, she had a little bit of bone to tendon healing, and keeping in the plaster, just let it settle down. Now, of course, she may be short, or the length may be long, and that's why she will have a little bit of loss of power, but she's still able to do it. And if you see her, she is a heavy lady. She was 95 short, 5 foot. And I thought going and doing a revision and everything would, and with an FHL reconstruction may not add much to it, and that's why I did that. But just a few points to learn from this.
No, I think the biggest lesson is don't be as aggressive as you want to all the time early. Sometimes nature will do its own thing without just, I mean, we all have these cases. You're like, that should be terrible. And you're like, I feel fine. You know, so do no harm. I mean, you did the right thing. There was no harm in waiting. And look, her outcome is absolutely fine. If she was an athlete, probably not good enough. But for a normal person, why cut her twice? It's amazing.
But things
don't
to learn.
X-rays anymore, okay?
Sorry?
No more X-rays. That's what
she was happy with it, and she never came back for follow-up further. So, and she was fine. But the point is, as you rightly said, if it is tight, do a gastroc, and I presume go more horizontal, and 2 anchors probably would be a better option. Balwinder, anything to add?
No, that's good to show that, sometimes you just have to do a master reflect as you're done and look at the patient as a whole. How's the patient doing and expecting? So I would not be. That's great.
Good. Okay. I think some questions are there, so we'll take that later. Next one, I would skip that. This is more trauma, so I will talk about tendinopathies. So I want to talk about something else. Okay. 52-year-old lady. She came from Kenya actually. History of glass injury to the front of the ankle, which was year and a half back. Came with, of course, weakness or difficulty in walking. There was hardly any dorsiflexion could be seen, and you can see this how she literally goes in a plantar flex, no dorsiflex, and this is the kind of scar in the front of the ankle. How would you assess and how would you proceed, Balwinder?
I think the location of the scar tells you that she possibly had a tibialis anterior tendon injury and maybe associated extensors of the toes also. So she has lost the power to dorsiflex.
Correct.
So, well, I personally don't have much experience in doing that kind of repair. If it is, how old is it now?
Almost year and a half.
Year and a half, right. So obviously you would want to explore the area and see if the tendon would have retracted much more proximally. So you'll have to visualize how much is the gap after you've done the debridement, how much is the distal stump, and if you think you can do kind of a tendon graft to bridge the gap there, that would be one option. And if not practical, then I would obviously think about doing a tibialis posterior tendon transfer onto the dorsum of the foot. But a tendon graft, because this is going to be a huge gap once you explore it, the tibialis anterior tendon graft possibly would be an option.
Adish?
So I've seen a few of these, chronic rupture, atraumatic. Rarely do we see this, but same concept is that I would definitely do a year out now. I wouldn't explore it. I would get a graft, whether it's a hamstring autograft or allograft, whatever, you need a graft. Make a small incision proximally, pull the stump out, pull the tendon, cut it. Then you have the proximal muscle bed that's viable. Make a small incision at the level of the medial cuneiform. Make a tunnel just like the peroneal tendon, and then use an interference screw to dock it and do a gastroc recession, typically, if they're loose, to balance the forces. because the anterior tib muscle is degenerated. It's been a year, so you're not getting the same power. You're trying to balance it. And the reason is that scar is a disaster. You don't want to get an infection. And if you open it and expose the entire anterior retinaculum, and the superior retinaculum is completely incised, your graft, as you put it in, is under tension. So you have to sew the retinaculum back together before you tension it. Sometimes that pops through, puts tension on the skin. So to avoid wound complication, that dual incision, which is what Mufuli has described for the Achilles, is a brilliant technique to minimize that scar, because the center part, you don't need to debride it. Nobody cares. Get the tendon in the sheath. It'll go right next to the scar, and you can avoid cutting that whole area because you know it's garbage there. So don't worry about it. Plan for the graft, small incision, proximal distal, dunk it, gastroc, and go home.
But what about the EHL and EDL?
That she's screwed on. So that's a tougher problem. If you want to try to reconstruct the EHL, you can try. I don't know if I would. I would just probably do an IP fusion and tell her not to worry about it, honestly. I've never reconstructed the EHL chronically, and to do a double graft, I guess you could. I've never done that, ever. That would be the only other option.
Okay. So what I did was, the first thing, as Balwinder said, I wanted to know how much are the ends retracted to, since it's been a year and plus. So I expected that they would be retracted a lot, and I would need to do either an allograft or a tendon transfer. So I got an ultrasound, and the good thing, look at this. This is my sonologist who has given me this diagram in my report. Okay, and she's looked at each tendon, and what she said is the tibialis anterior, there is only a 1.8 centimeter gap. EHL is only 1.5 max, and EDL is only less than a centimeter. So when I saw this, I said, fantastic. I think I could do a end-to-end repair. Okay, because though the edges, the ends have not retracted, and they are in the scar tissue. So for the sake of time, opened it up. I could see all the tendons. The scar tissue was there. Removed the scar tissue, could do an end-to-end repair. And finally, she did well. She went back to Kenya. This is the video she sent. She has dorsiflexion. She has individual EHL, EDL movement, and she doesn't drop at all. Super. Look at that, those movements, individual movements of the toes.
That's amazing, man. Damn good.
Yeah, but I'm not sure you'll be able to get an active dorsiflexion.
But she's getting into active dorsiflexion. I thought she had
beyond neutral,
So,
and
yeah,
maybe it down because you have. I mean, yeah, obviously the gap was a bit less, so you did the right thing. You could bring the same tendon down after a year and suture it back, right? You didn't have to do any tendon graft.
Nothing.
Oh, that's a bit surprising me, because the muscle generally contracts at the end of a year, and it's difficult to bridge the gap just by bringing the tendon down onto the original level of the cut and doing a repair without tension. But that's amazing.
What
Did you repair the retinaculum, Pradeep, or just skin?
No, retinaculum. I did, and that's why she doesn't have the tethering, the bowstringing.
I'm shocked. Looking at that intra-up picture, I would have said 0% chance. Where the hell's retinaculum?
Yeah,
I'm impressed.
there's no retinaculum. But
Why did it die?
Yeah, the retinaculum.
You are a damn good or lucky guy.
But I'll tell you, I'll show you some more pictures. Okay, so when we say you excise the whole, all the scar tissue, do not do that. I have another case which I have not put it in. Again, a year and a half down the line, tibialis anterior tone. But I have kept the fibrous tissue and repaired it, and it works. And I'll show you this picture, this photograph. 52-year-old male, 5 weeks injury, weakness, difficulty, weak plantar flexion, Thompson test positive, no gap. Look at that. Nothing moves. Okay. I could feel the gap as well. I thought I could feel the gap. So, there.
Seems I'm okay.
Okay, so just for the sake of, I'll run through it. When I opened it up, I could not see the gap.
Right?
Yeah, there. That's a complete full tendon.
You said it was 5 weeks.
5 weeks. He's been working on this. Okay, you can see this whole continuity. So opened it up, found where the gap could be felt, or tissue which is not a tendon tissue and a scar tissue, that's been excised, and then that was repaired. Okay, and of course you can see that Thompson's will be negative as well. Okay, another case, similar case, so we'll discuss that. 32-year-old, he had a misstep 4 weeks back, and afterwards, when he came to me, young chap, I said, you need a surgery. This is the MRI scan, which shows here, that's the tear, which you can see. There is the tear. Okay. So he said, okay, doc, I need to ask my mom who is in village. Let her come back from the village and then I'll get it operated. So by the time he came on the table, it was almost 6 to 7 weeks. And this is where I thought I could feel the thickening, and I marked it as correlating with the MRI scan. When I opened it up here, you could see this whole thing continuous. Okay. Now what do you do?
Yeah,
Anish?
just cut out the scar and drop it together, man. It's not been, you don't need a graft. If it's 3-6 months, different, but in this case, that's what the Achilles will do. So just cut out you can see that translucent tissue needs to be cut out.
Correct. So exactly. So just opened it up. What I did, I took a cut there and looked where I could go from a scar tissue to a normal tissue, cut it out, and just did a primary repair. And he did quite well as well, where this is 3 months down the line. He could walk on tiptoes, do everything. Okay, and this is the paper which has been from direct repair of Achilles tendon using scar tissue located between the tendon stumps. They've shown excellent results where you can use the scar tissue in your repair. So if you have a little bit of lens short, don't discard the scar tissue. You can repair it, and they do good results. Give you good results. And probably it shows from both the tibialis anterior tear and the TA tear as well. Okay.
Yeah. Great job, man.
Balwinder, any questions, comments?
No, I think we are completed 2 hours and there are a few questions. Do you want to go to the questions maybe?
Yeah. Okay.
And then
So,
we'll rapidly answer the questions.
Yeah. So above knee cast, I don't do any above knee cast. Do you guys do any above knee cast?
No above knee cast, no.
No.
Always below knee.
Always
Yeah.
below.
Yeah. Okay.
You never need an above knee cast if you're doing something, because biomechanically we are able to restore the stability somehow, that you shouldn't need a above knee cast. Something's wrong if you're doing that.
So Dr. Kapil asked, after excision of calcific part of Achilles tendon and Haglund's, if gap is present more than 2 centimeters, will you recommend FHL plus gastroc, or either of the two, or which one? Anish? 2 centimeter gap?
Usually I can get away with a little bit of a tight repair and a gastroc for 2 centimeters. Once you get above 2.5, then I will start doing a graft or a turn down if I don't have a graft. With 2, you can usually just do an aggressive gastroc, which is a poor man's VY, and then you just put them in Aquinas and they'll be okay.
Okay. So how do you perform a gastroc recession? Do you perform in conjunction with a FHL? I think we have answered that already. Maybe your repair. So that was the one which my anchor came out. He said the repair was too tight and the anchor moved up is because of that. I think we agree with that. And also probably the anchor position could have been a little bit more horizontal. And now probably adding 2 anchors would be a better option. Correct?
Yes. Yes, I think so.
Yeah.
100%.
Now, do you have assess the muscle by MRI before tibialis anterior rupture? I don't think so. We did that. I think a dynamic ultrasound was done to just see the edges. But point by Balwinder was raised, like 1 year down the line, do you think the muscle would still be a little bit active, or you would just go for I think you would still, even if you did a tendon transfer, you would still have to rely on the tibialis anterior muscle. Correct?
Yeah. your choices are so limited. It's either a posterior tendon transfer or you go for gold. And the anterior tib seems to work okay. Even after a year, you still are okay somehow. It's not normal. They may get 5- out of 5, but they somehow still do okay with an anterior tib tendon transfer because it's not a power move, right? It's just to clear the foot off the ground. They usually do fine, even though there may be some fatty infiltration. Usually you're okay.
Excellent. Great. Any burning questions, Balwinder?
Great. No, lovely. Thank you.
Thank you.
Thank you so much, guys, for spending your time, both Balwinder and Anish. Anish, I know you've been quite busy, but really, really appreciate that.
My pleasure. My pleasure. Take care, guys.
Thank you, Balwinder, as well. Bye.
Thank you.
Bye, guys.
Anish,
Bye.
bye-bye. Take care.
Bye.